Well, good evening, everybody. Welcome to tonight's lecture. Vet Education is proud to present a free lecture on management of sepsis, what works and what doesn't. This free webinar has been brought to you by the Vet Education 4-week online course titled Management of Severe Systemic Illness in Small Animal Practice. It starts this coming Monday, so we're thrilled that you could come along for this introductory lecture. A little bit of a taster as to some of the things that we'll be talking about during the course. It's lovely to see people from all over the world joining us for tonight's lecture. Welcome to everyone. I see quite a few familiar faces from all over the place and quite a few new ones as well. So welcome to everyone for tonight's lecture. A couple of housekeeping things just before we make an official start. You will find handouts for tonight's lecture, not only in the email that you got earlier today, but there's also a handouts tab at the top right of your screen. You'll click on that, you'll find the handout there. You can just download it. If you have trouble with that, we do have wonderful Danielle, who is technical support person this evening, and you will find Danielle's name in the private tab. You'll see that also in the top right of your screen. Danielle, thank you so much for being our tech support guru again tonight, Danielle. If you just click on Danielle's name, you can start a private chat and tell her about any issues you might be having with sound or vision. But I have also put in a little box at the top of the screen on the right hand side as well, just welcome to the lecture this evening. If you have any technical issues, just try closing any other apps or programs on your device that might be using a bit of internet bandwidth, and then close your browser and reopen the lecture link in either Firefox or Chrome. That does help with a lot of people's technical issues, but as I mentioned, Danielle is there to help as well. A lot of you have found the chat there on the right-hand side of the screen, so please type in questions as we go. I'm happy to take as many as I can during the course of the session, and that will do a final wrap-up towards the end of the lecture. This lecture is being recorded, so if you have to step away for whatever reason, please don't stress. You can catch up, and I'll try to get this lecture edited for you tomorrow so we can get that to you before the weekend. Now, I do have a special announcement, because in one of the emails you were sent, I said we had a special surprise or gift for you, and that is coming up, especially for all of you who have turned up to the lecture. And I know for some of you, it's very, very early in the morning, and some of you in the middle of the night. So we're going to make it worth your while, and that announcement is coming up towards the end of the lecture. So please stay tuned for that special announcement that we have for people who have come along to this lecture. I think we should make an official start. But I think we'll make a start with tonight's lecture, and that is sepsis, what works and what doesn't. Why are we talking about this topic this evening? Well, sepsis is life-threatening. If you have a patient that develops sepsis or worse, septic shock, they have a reasonably high chance of not surviving their illness. Even today in 2023, morbidity and mortality remain quite significant. However, several reviews suggest that over the last 10 to 20 years, that mortality rates are decreasing. So what I thought we would do is examine why they are decreasing, what helps mortality rates decrease in patients with sepsis, and also importantly, what doesn't necessarily help with patients with sepsis in terms of altering mortality. So let's get on and talk about what has not worked in patients with sepsis in terms of improving survivability and reducing morbidity and hospital length stays. Now, this data predominantly comes from the human literature, because our data in veterinary science is fairly small, despite some great efforts by a number of really dedicated veterinarians to increase the amount of literature available in sepsis in dogs and cats, we still have quite small numbers in our studies. So a lot of what we'll talk about tonight is based on human literature. But I want to make the point that I will let you know as we go through tonight's session what is applicable to dogs and cats and what we do know is not applicable for dogs and cats. So let's get underway. What has not worked? Well, I don't know about you, but I remember hearing some time ago that there was a great deal of fuss and quite a bit of excitement about targeting various inflammatory mediators and anti-inflammatory mediators in patients with sepsis in the hope that we could prevent the scale of inflammation, the scale of systemic illness from getting to the point where it caused sepsis and septic shock. Unfortunately, what has not worked is pretty much all of those molecules that target signaling molecule inhibitors and also targeted signaling molecule amplifiers. So medications that have been developed to target specifically signaling molecule or inflammatory mediator inhibitors or inflammatory mediator amplifiers have failed to make any difference at all in terms of survivability. The clinical trials evaluating sepsis modulating therapies show no improvement in survival and no improvement in disease severity. There are a few reasons for this, and that is sepsis is quite a complex disease process. It's the common pathway for quite a number of diseases involving various different organ systems. So there are fairly disparate causes from trauma to infection to diseases like pancreatitis, for example, and pyometra, those kinds of conditions. And in sepsis itself, there are both pro-inflammatory phases of the systemic illness and septic disease process, and also some anti-inflammatory phase as well. And so one can imagine that if you just targeted an pro-inflammatory molecule and your patient had a predominance of an anti-inflammatory phase in their illness, that maybe that molecule may not work terribly well. Patients with sepsis also have a hyperdynamic phase where they may have increased heart rate and blood pressure, uneven vasoconstriction and vasodilatation, or they may have a hypodynamic phase characterized by low systolic arterial blood pressure, negative inotropy, profound vasodilatation throughout the body. And so we can see that targeting signaling molecules against one particular part of the inflammatory or systemic response may not necessarily apply to animals or people across the wide spectrum of disease presentation in sepsis. In addition to that, the doses required for effective activation or inhibition of inflammatory mediators are pretty much unknown. Scientists have developed, antibodies or signaling blocking molecules against tumor necrosis factor alpha and some of the interleukin cytokines that get released from white blood cells, but we don't really know the dose of these medications that might result in inadequate inhibition of the action of these molecules. And the treatment protocols have varied in terms of global patient care. So in some trials where signaling molecule blockers have been used, or inhibitors or agonist molecules, the remainder of patient care has varied quite significantly, and this may have blunted some of the response that we see from these clinical trials. But what we understand right now at this point in time, and we know that science is fluid, science doesn't know everything, otherwise it would stop, right? So we know that this landscape might change a little bit, but in this particular point in time, anti-inflammatory and immunomodulatory medications are unlikely to be effective across the broad spectrum of patients with sepsis. Anti-inflammatory therapy such as corticosteroid medication and among others has also not been shown to alter survivability or patient illness either. There are some other anti-inflammatory medications that are already alluded to, antagonists to some of the inflammatory cytokines like tumor necrosis factor alpha and interleukin-1, antibodies to endotoxin, and of course we mentioned just before corticosteroids. None of these have worked. So we tend to avoid those. We're going to not worry about those in our patients. I want to focus mostly for tonight's lecture on what has worked, because there are some really cool and interesting things, practical things that you and I can use in our practice to help improve survivability of patients with sepsis. There are a number of things. I'm going to run through them over the next 2 or 3 slides, and then we'll focus on some of the really important ones. What has worked is an increased awareness of patients that have sepsis or that might develop sepsis. And this can involve, early diagnosis of patients with sepsis. And this really underpins what follows on from an early diagnosis, and that is early treatment. The earlier we can diagnose a patient at risk of severe systemic illness or sepsis, the earlier we can begin treatment, and this is found to result in improved outcomes. Early antibiotic therapy, early source control, that is removing any septic or infected focus from our patients' bodies, early institution of vasopressor and inotropic support, so using drugs like noradrenaline or norepinephrine, depending on where you're from, can be associated with better survival rates than leaving it until the last minute. And early organ support, so monitoring patients at risk and then beginning support for a failing organ as soon as detection of abnormal function is noted. We also know that improved standards of care can also result in improved outcomes. That is, avoidance of things like fluid overload as well as dehydration, but we know a lot about fluid overload, and I'll talk a tiny bit about that tonight. Transfusion therapy, this is a topic of significant controversy. I've written judicious use. Now, you and I both know that the word judicious sometimes cannot be terribly helpful, and that it doesn't tell us how much we should use. So we'll talk a little bit about that and the value potentially of early transfusion therapy. There's a question mark there for a good reason. If you need to ventilate a patient with sepsis, then using lung protective methods of ventilation therapy is worthwhile. And nutritional support aimed at really only replacing our resting energy requirements, avoiding excess calories, and also really tight glycemic control. So patients that are hyperglycemic, we are now starting to administer insulin continuous infusions to really pull hyperglycemia under control, because hyperglycemia in septic patients is associated, independent of everything else, with an increased risk of organ dysfunction and organ failure and subsequent mortality. So those are key things there. What else have we got? Oh, the use of bundles. And now bundles, for those of you who are not familiar with them, are basically standardized groups of checklists and diagnostic tests and treatment protocols that are bundled together in a group that we can use in our patients at various times following hospitalization. What they've found, and we'll talk about this later on, is that the use of these bundles is associated with more standardized care, less things get overlooked, and survivability from sepsis improves. So we'll talk about that a bit later on as well. The other thing I just wanted to mention about what has worked is early recognition of complications using, again, those bundles, standardized diagnostic tests and standardized treatment triggers. During the sepsis course, or the management of severe systemic illness course that we are going to be running starting next week, we are going to include a lot of these bundles. Now, Jose, any resource where we can find these bundles? Yes, there is. It's called the Surviving Sepsis Guidelines. They're guidelines that are produced for humans. So we need to be careful, and I've got some tips as we go through the lecture tonight as to which ones we should follow and which ones perhaps are not applicable to dogs and cats, because we have literature to suggest that they're not all that helpful. So But if you start with the Surviving Sepsis guidelines, which we'll talk about later on, then that's a good place to begin. And other interventions that we might find work are immune stimulation. So let's just go back a couple of steps and talk about some of these critical things in a bit more detail. This first section about increased awareness of sepsis is really crucial. Many of you will have graduated a few years ago and may have encountered some definitions for SIRS, Systemic Inflammatory Response Syndrome. And these definitions were developed in the early 1990s, and they were basically designed to try to detect people that had signs of severe systemic illness, systemic inflammatory response syndrome. And the symptoms included tachycardia, tachypnea, either an elevated or decreased white blood cell count, and either high body temperature or low body temperature. Now, you and I as veterinarians, we'd say, well, actually, most cats that present to our practice for mild illness would fit the definition of systemic inflammatory response syndrome, because in people, you only needed 2 of these to be classified as having systemic inflammatory response syndrome. So I'm thinking automatically of a cat that's not that happy being brought to the vet clinic that maybe has something reasonably minor, like a cat bite abscess, for example. It might have tachycardia, and it might have an elevated white cell count, or it might have hyperthermia. And that patient, yes, they are mounting a systemic response to an infection. Do they have systemic inflammatory response syndrome that could lead to sepsis? Well, if it's untreated, maybe, but we can see that there are a lot of chances here for false positives. And in fact, in human beings, they found that these old definitions did lead to quite a lot of false positives, so very poor specificity in this particular test. So fairly low specificity in these old definitions. So early on in the 2000s, I think 2002, 2003, they developed some new definitions. In fact, the old term of systemic inflammatory response syndrome is being phased out. And what they now have is what's called the Sepsis 3 definitions, based on something called the SOFA score. Now, the SOFA score stands for Sequential Organ Failure Assessment Score. And it's a scoring system that basically assesses the performance of organ systems like the brain, the liver, kidney, your hemodynamics, blood pressure, and so on, and just assigns a score based on the results of each particular category. And this is an example of the SOFA score that is used in people. I have put this in the notes. You don't need to pay too much attention to this because it has not been validated in dogs and cats. In fact, there was a study that found that the use of the SOFA score, and then there's a quick version called the Quick SOFA or Q SOFA that just basically defines you as having severe systemic illness if you're hypotensive, tachycardic, and with a Glasgow Coma score of less than 13. In people, they found that the use of SOFA and Q-SOFA improved the sensitivity and specificity of identifying patients at risk of death. So this works really well in people. There was a study that looked at the use of SOFA and Q-SOFA scores in dogs and cats and found that it has quite a poor sensitivity and specificity. Now, I've written something that for animals, we tend to want to use the Apple score, and that's what I would recommend. It is a scoring system that has been validated for both dogs and cats. What is an Apple score? It's the Acute Patient Physiological and Laboratory Evaluation. Okay, so that has about a specificity of 85% if you take a score above 25 to predict death on admission from your patients on admission. So Apple scores are utilized in dogs and cats. I have to say that getting the Apple score does involve a little bit of maths. And during the course that we are running, we will actually be simplifying this whole thing. I'm in the process of producing a table that will enable you to plug the Apple score into this table and come up with a result. We're also working on developing a little Apple score calculator for you as well, so that you can essentially get a score based on the blood tests, physical observation, and things like that you're getting, and you'll be able to come up with a number that has a fairly good sensitivity and specificity for mortality risk in your patients. But that is what we're using in dogs and cats. So basically the aim, if I can just go back a slide, the aim of these scoring systems is not necessarily to condemn a patient to death because they get a particular score. But what it does is it helps us identify at-risk patients so that we can monitor them more closely, we can treat them more aggressively, and hopefully treat them earlier so that their chances of survival from their illness is improved. And that is the whole idea of these scoring systems. It's not to say, oh my goodness, you have an Apple score of 35, you're going to die. It's a matter of saying, well, your Apple score is 35, you're a really sick patient. I need to monitor and treat you with a great deal of attention to all of the things, including the things that we'll talk about tonight, to optimize or maximize the chances that you might recover. What about immune stimulation? We mentioned a little bit about, blocking molecules and anti-inflammatory medication not being terribly helpful in terms of reducing mortality and morbidity. What about immune stimulation? Immune suppression is pretty common in sepsis. We mentioned that there is both an inflammatory and an anti-inflammatory phase of patients with severe systemic illness. So immune suppression is pretty common in patients with sepsis. Actually, increased or heightened immune function is also common in sepsis. In that pro-inflammatory phase of sepsis, we have heightened activation of the immune system. In the hypodynamic phase of sepsis, we have patients typically with immune suppression. So immune suppression actually seems to persist in septic patients beyond that acute pro-inflammatory phase. And in fact, most people with sepsis who end up dying die in part as a result of complications from the anti-inflammatory or immune suppressive phase of their systemic illness. So that is a significant complicating factor in patient management. So immune suppression is really common. We get reduced leukocyte chemotaxis, so it's less likely for those leukocytes to be attracted to sites of injury or infection. There's reduced neutrophil production of reactive oxygen species. I think superoxide, for example, would be one. Ozone, hydrogen peroxide, those kinds of products that are involved in innate defense. There's reduced monocyte cytokine production. So the inflammatory chemicals or the chemicals that help mediate or modulate the inflammatory response is reduced. There's increased release of incompletely differentiated myeloid suppressor cells from the bone marrow, leading to decreased T cell activation and increased interleukin-10 production. Now, interleukin-10 reduces activation of macrophages. This is one of the reasons why we end up with immune suppression and decreased chemotaxis and so on. So these are some of the things that happen with immune suppression. The diagnosis in the laboratory is based on detecting elevated interleukin-10 concentrations or increased interleukin-10 to tumor necrosis factor alpha ratios. We're not measuring these all that commonly in veterinary medicine, but essentially, if you have a patient that is suffering from sepsis, even if you're not able to detect alterations in interleukin-10 concentrations, but you have perhaps decreased white blood cell count, you have a patient whose infection is not getting under control with antibiotics, even though the antibiotics may be, or the bacteria may be sensitive to the antibiotics you're using, or you may have an immune compromised patient, a patient who has neoplasia, who's on immune suppressive or anti-neoplastic medication, a patient with immune-mediated disease who's on immune suppressive medication. These patients are at high risk of developing severe sepsis and dying. So the use of things like granulocyte colony stimulating factors, which is GSF, interferon gamma, T-cell stimulators, and interleukin-7 can be associated with improved outcome. To date, only the granulocyte colony stimulating factor and interferon gamma have been subjected to extensive study. The other two, interleukin-7 and T-cell stimulators, are still in their infancy when it comes to study. But what they've found is that granulocyte colony stimulating factor in people results in fewer ICU days and lower illness scores. Interferon gamma is associated with improved outcomes, so reduced mortality. And some preliminary animal data on the use of interleukin-7 shows that there is improved outcome in sepsis and experimental models of sepsis in dogs and increased lymphocyte numbers and function. For those of you who are working in places that have Ehrlichia, certainly the use of granulocyte colony stimulating factor has been used in a number of patients that have quite significant myelosuppression and has been found to be quite useful in terms of raising white blood cell counts in those patients. So certainly I think we have a lot more information to gain from the use of these chemicals in people. I think that in an immune suppressed patient, that perhaps the use of granulocyte colony stimulating factor seems to be reasonably safe based on conversations I have had with colleagues in particularly Ehrlichia endemic regions as well. So it may have some benefit in immune compromised patients that have got severe systemic illness. What about early antibiotic therapy? Early antibiotic therapy is associated with improved outcome. Okay, the mortality rate can increase by 7.5% to 9% for every hour delay in antibiotic therapy. Think about that for a minute. For each hour that you or I delay antibiotic therapy in a patient with severe systemic illness or sepsis, the patient's risk of mortality increases by 7.6 to 9%. Wow. The odds of mortality increased 4% for every hour antibiotic was delayed in another meta-analysis, and the odds of mortality were 49% higher if antibiotic therapy is delayed beyond 6 hours compared to if it was given within the first hour of diagnosis of sepsis. So this, I think, ties in really nicely with that early disease recognition. If we have a heightened sense of awareness of what sort of patients have or are likely to develop sepsis, or we have perhaps put a dog or a cat through an apple scoring system and have decided this animal has severe systemic illness, the earlier we start antibiotic therapy, the lower their mortality rate is. Now, what antibiotic should we start with? There was an interesting paper that suggested that it didn't really matter if the antibiotic that you used was sensitive against the invading microorganism, because most infections in patients with sepsis tend to be not only from a single microbial agent, but oftentimes due to lots of commensals. So start with a broad spectrum antibiotic. Usually I'm starting with a beta-lactam antibiotic, amoxicillin, first generation cephalosporin, okay? To begin with, we can refine our antibiotic choices. We can escalate if we need to, if we gain a sample for culture and sensitivity and find that our antibiotic is not sensitive to it. Then we can change the antibiotic or escalate our antibiotic choice if necessary. Or if you've got a severely systemically ill patient with immune suppression, you might decide that you're going to start with a beta-lactam antibiotic and maybe a fluoroquinolone, maybe even metronidazole. You can de-escalate, so reduce the number of antibiotics that you're using as soon as you identify the causative organism and what it is sensitive to. So that is the approach that we're going to use. Now, I just thought we'd take a little pause and just remind you that this lecture is being brought to you by this amazing course. I'm telling you, it's amazing. I'm writing the course in the next few days. I have been for the last few weeks, and there's so much really interesting and exciting stuff in there on the management of severe systemic illness. We're going to expand on a lot of the stuff we're talking about tonight during the course and introduce a whole bunch of other stuff. It's a 4-week course, starts Monday, September 25. So that's next Monday. So that there, and then I do have a special announcement with a very special offer for you guys tonight as well. I've just seen a couple of questions there. Is there any difference on outcome depending on the class of antibiotic used or a combination of antibiotic used? It doesn't seem to be. Zhao, thank you for asking that question. And hopefully I answered that just before, that pretty much it doesn't matter what you start your patients on. I would be starting them off with a broad spectrum beta-lactam antibiotic. What I probably don't want to do is to choose, a 3rd generation cephalosporin or something that I save up for patients who have got a specific infection. I'm going to start off with a garden variety mainstream antibiotic, such as amoxicillin. Amoxicillin clavulanic acid would be fine to use to begin with. Maybe I might, in a really, an immune compromised patient, I might add in metronidazole if I've got infection or inflammation in an organ system where I suspect there's anaerobes in there, big abscesses, for example, lower GI problems, those kinds of things. Or I might add in enrofloxacin if I'm worried about gram-positive and gram-negative aerobes. So, things like skin infections, for example, I might add in fluoroquinolone, but then I can de-escalate or escalate depending. Now, Zhao has asked the question, can I clarify, is there a contraindication or indication for not using non-steroidals in septic patients? I love that question. Zhao, thank you again for asking such a good question. Non-steroidal anti-inflammatory drugs are contraindicated in patients with sepsis for a couple of reasons. One is that I don't know what my patient's blood pressure is going to do. And if I give a non-steroidal anti-inflammatory drug and my patient becomes hypotensive and I run the risk of that patient developing acute kidney injury, if I've given my patient non-steroidal anti-inflammatory drugs, my risk of acute kidney injury goes up. Okay, these risk factors for organ dysfunction are additive and cumulative. So I don't want to give my patient something that might cause that patient to develop the GI or kidney dysfunction, or in some patients, idiosyncratic acute liver necrosis or acute liver failure secondary to non-steroidal anti-inflammatory drug administration. So that's the first reason. The second reason that they are contraindicated is that there's no evidence that they would provide any benefit for the patient in terms of altering morbidity or mortality. Sean has asked a question. You had a case with almost no neutrophils. Should we use something to stimulate neutrophil production? I would be using granulocyte colony stimulating factor rather than an anti-inflammatory drug. So that's an answer to that question. Let's talk about something else that we can do in practice. We talked about early antibiotic therapy, early recognition of patients with severe systemic illness, early source control. This is a subject of debate because let's say you have a dog that has been attacked by another dog. It has bite wounds all over its body, but hemodynamically that patient might be quite unstable. Or let's say that you have a patient that has significant infection already. Maybe it's a trauma patient. Maybe it has wounds that you need to clean up, but the patient is hemodynamically unstable. When should we try to debride and remove a potential source of a problem? Well, there's a couple of papers, and I have to say that even though we're in 2023 and we like to think that our knowledge of things is reasonably good in 2023, even in 2023, this has been relatively poorly investigated in terms of patient numbers and conclusions to date, even in human medicine. I don't believe that there's much in the way of studies in animals either. But a couple of years ago, there was, actually probably since 2014, there have been just a few studies that have appeared in the literature in people that have associated early source control with reduced mortality. But to take a step back, on this slide here, we've written that mortality rate is lower in patients with sepsis who have had source control. Okay, so if you do something about the source of your patient's inflammation or sepsis, so that might be removing dead and damaged tissue following a dog bite wound, or it might be providing wound lavage and wound care in patients with significant soft tissue injury. It might be that we are doing an abdominal surgery for a patient with a ruptured bowel, okay, and or doing surgery to manage a patient with a ruptured gallbladder that's got septic peritonitis as a result of that. If you do something to address the source of the problem, patients' mortality rate decreases, even if you're not using bundles and things that we're going to talk about later. And even if the standard of care in that you're able to provide doesn't have all of the bells and whistles that maybe a big referral hospital has, if you do something to control the source, your patient's survival rate will improve. So this is something that we can all do. Interestingly, mortality rate is lower if we do that surgery for source control or try to achieve source control within 6 hours of hospitalization. So let's apply this to bite wounds, abdominal surgery for ruptured bowel or something. If we do something within 6 hours, there is a significant reduction in mortality rate. This has much higher significance in patients with gastrointestinal injury, and so torsion, rupture, intussusception, those kinds of things. Patients with any kind of abdominal disease, usually peritonitis, ruptured urinary tract, ruptured gallbladder, ruptured intestine, and so on, and with soft tissue injury or infection. So note that injury and infection are two different things. If you have a dog bite wound or a road traffic accident patient who has significant wounds, the earlier we can debride those wounds, the better our patients have chances of survival if they develop severe systemic illness. Okay, so this is as opposed to orthopedic injuries such as fractured limbs, or in fact in cranial trauma, there's less of a clear line as to whether or not surgery within 6 hours for those patients is of value, but it is significant in patients with gastrointestinal injury, abdominal disease, and soft tissue injury or infection. So those are the ones I'd focus on doing surgery within that first 6 hours or so. Now, I'm going to go back a slide because we need to strike a balance. In patients, and I know I'm picking on dog attack victims, but so many of these patients that have big dog versus little dog bite injuries or dog versus cat, and this poor animal comes in with significant body trauma, many of these patients can develop severe systemic inflammation. Please type in the chat if you have seen patients with peripheral edema or edema all over the body, patients who develop pulmonary edema, increased respiratory rate and problems with that, perhaps developing azotemia, they'll vomit, they may get hemorrhagic diarrhea and so on after those sorts of traumas. Okay, so those sorts of patients that have these injuries, we need to strike a balance between the length of time that sometimes it takes us to stabilize our patient and when we go to surgery. So there may be times in which we are taking patients to surgery when they are not completely hemodynamically stable. And so that does increase the potential for risk of anesthetic complication. However, that needs to be balanced against leaving a septic focus or an injury focus in my patient that is going to lead to the generation of many, many more times the number of cytokines and inflammatory cells and debris and those sorts of things, and potentially increasing the risk of infection in my patient. That could mean that my patient may never develop hemodynamic stability. So we need to try to do everything we can in the first few hours of therapy in order to try to improve our patients' hemodynamic stability, and then to try to take them to surgery. Now, there's a couple of good questions here. What drugs do we use to control pain associated with sepsis? Opioids, any concern on GI stasis and gastrointestinal bacterial overgrowth? Opioids are great, and I would add into your opioids lidocaine and ketamine if it's a dog, and maybe ketamine and opioid if it's a cat. We tend to be a little bit more shy with lidocaine continuous infusions in cats because the toxic dose is a little closer to the therapeutic dose in cats. So I like to use local nerve blocks in cats. So if there's, epidurals, for example, local nerve blocks, intercostal nerve blocks where there's chest wall trauma, limb blocks, so local nerve blocks as well with fractures of distal limbs and so on, in combination with opioids and ketamine. How can we differentiate sepsis from SIRS? Only from cultures or evidence of infection or purulent material? That's another great question. So it can be quite difficult to distinguish SIRS from sepsis without a culture. We might be able to diagnose sepsis from SIRS based on just simple cytology, and we might see evidence of bacteria in part of a source, perhaps a bite wound or urine, for example, that we have got, or from any sort of wound in our patient. And that might give us cause to think that our patient might have sepsis. But the differentiation between sepsis and SIRS, sepsis is really just systemic inflammation with an infectious component. Now, the infection can either be the cause of the systemic inflammation due to the release of endotoxin and so on, or it may just be a complicating factor of severe systemic illness. Picture a patient with pancreatitis, for example. It's initially oftentimes a sterile disease process that can become complicated with infection if you get bacterial translocation from the gastrointestinal tract into systemic circulation, along with the patient's systemic illness caused by the pancreatitis. So there's oftentimes a bit of a blurry line in that picture there. When would we give antibiotics? Well, if you've got evidence of an elevated or decreased white blood cell count, I think that antibiotic use in those situations would be ideal. Or if you have puncture of a body cavity, because we know that that's a dirty wound that's going to get infected, or if you have dirty wounds, those patients invariably will get infections. So those are the kinds of situations in which we're starting antibiotics before maybe we get a diagnosis of sepsis in patients with severe systemic illness. All right, let's look at vasopressors and inotropes. How many of you are using vasopressors and inotropes, drugs like noradrenaline, maybe using dopamine or dobutamine, something like that in your practice for these severely systemically unwell patients? Typically, we're going to consider the use of vasopressors in patients that have intravenous fluid therapy that does not result in improvement in blood pressure. We usually then back off on our IV fluid rates a little bit, and we start our patients on vasopressors and positive inotropes. Not necessarily always both, usually vasopressors to begin with and maybe positive inotropes later on. The drug that has been associated with the greatest improvement in mortality rates and morbidity rates is noradrenaline. So if you have a hypotensive patient, a patient who remains hypotensive despite intravenous fluid boluses, let's say it has a systolic arterial blood pressure of 85 millimeters of mercury, you give your patient shock rates of fluids for 10 or 15 minutes and that blood pressure does not change at all, I would not be giving my patient more intravenous fluids after that fluid bolus. I would be decreasing the fluid rates to maintenance rates and starting my patient on a vasopressor. And noradrenaline is the one that I'm going to reach for because it has both positive inotrope and some vasopressor effects. Its use is associated with lower hospital mortality when compared to dopamine, so it is better than dopamine. There was a 5.3% increase in mortality in people for each hour delay in noradrenaline administration after the diagnosis of shock. So of septic shock. So the definition of septic shock is a patient that is not responsive to intravenous fluid boluses that has evidence of systemic inflammation, okay, or sepsis. So a patient that is characterized as having severe systemic illness or sepsis that does not respond to intravenous fluids is in septic shock. And those are the patients that earlier you can give them noradrenaline, the better their survival rate is. Now, a couple of questions there that I will save up for later on. Would I reach for noradrenaline first under general anesthesia as well? It depends a little bit on the patient, Dina, and thank you for asking that question, because if I have a non-septic patient, let's say it is a patient who I'm doing surgery on for fracture repair, for example, or some other relatively non-critical illness, and that patient develops hypotension, there's a whole bunch of things I'm going to do before I reach for a vasopressor. But likely in non-systemically unwell patients, it may not matter too much whether or not you give dopamine versus noradrenaline. So if you have dopamine in your practice, then you could use that instead of noradrenaline. You could use noradrenaline, I'm certainly not against that in that situation. If you have a septic patient, a patient with a GDV, a patient with a ruptured bowel, a patient with a dog attack victim that you are taking to surgery to manage its source control, and that patient develops hypotension, and I've done everything I can, I've reduced isoflurane rates, maybe trialed a fluid bolus, maybe I've given my patient a positive chronotrope if the patient is bradycardic. If none of that stuff has worked and I need to give my patient a vasopressor, then I would use noradrenaline. Okay, so that would be the first vasopressor that I would use. So that is what we are thinking about in these patients. Dopamine is not found to have any benefit over noradrenaline. It's slightly more arrhythmogenic and is associated with higher mortality rates. So in septic patients, the dopamine is very much a second choice. Vasopressin is an interesting one. Vasopressin plus noradrenaline actually increases gut and kidney blood flow. It reduces the dose of noradrenaline required to achieve normal blood pressure and may also reduce 28-day mortality rates. So the use of vasopressin in combination with noradrenaline, vasopressin doesn't really do too much to the heart, so it's not a positive chronotrope or a positive inotrope at all. It's just a vasopressor, like its name suggests. And so it's quite a useful thing to use if you're finding that the dose of noradrenaline that you are needing is getting to the point where you're starting to see some tachyarrhythmia starting to appear. Adding in vasopressin might reduce the dose of noradrenaline required to achieve normal blood pressure. All right, dobutamine is an interesting one. Dobutamine is a pure positive inotrope. It does cause a little bit of vasodilatation. Interestingly, when it's being compared to dopamine in terms of being a positive inotrope, in patients with sepsis, it carries a lower mortality risk. Overall benefit in using dobutamine over noradrenaline is a little bit unclear. So most clinicians are perhaps using dobutamine if they haven't got noradrenaline in their hospital or practice, and they're using dopamine purely as a vasopressor. They'll add in dobutamine as a positive inotrope. Why would we need to use a positive inotrope in a patient with sepsis? The reason is that two cytokines in particular, nitric oxide and platelet activating factor, are potent negative inotropic agents. So the contractility or the force of contractility in the heart muscle is reduced in patients with sepsis. One of the reasons noradrenaline is so helpful is that it's a vasopressor, but it's also a positive inotropic agent too. But if you're not using noradrenaline, if you can't get hold of that and you're using dopamine in your practice, use dopamine as the vasopressor and use dobutamine as the positive inotrope. So I'm just going to pause for a second and answer a couple of questions. Let me see. Max has said, as you explained, I had an exact case last week with noradrenaline was the lifesaver, fluid boluses and dopamine made no difference. You sometimes will find that for sure. Should we be careful about IV access with noradrenaline? You need to make sure that your intravenous catheter is good, because it is a potent peripheral vasoconstrictor and you can get some skin necrosis. So some people prefer to use this in a central line, but if you don't have a central line in place, make sure your catheter is patent and working, that it's a good catheter placement, that it is not associated with any swelling around the catheter, in order to avoid the possibility of causing some issues with that. So thank you for raising that comment as well. Let me see. What would you recommend for hypotension in a case of FIP with sepsis? Human albumin transfusion or vasopressors? Vasopressors for sure. And I'm going to talk about human albumin transfusion right now. So thank you for asking that question. If we don't have any of the options we've talked about, is adrenaline better than nothing? Yes, it's better than nothing. It's very arrhythmogenic, and you really need to be very, very careful with it. Probably you are better off using vasopressin if you could get it, but I would really be trying to get noradrenaline into your practice if you at all can. If you can't, then dopamine's probably okay as a second line of choice. The problem with adrenaline is that it activates everything. It's a positive chronotrope, a positive inotrope, so you get a tachycardia with it as well. It's quite arrhythmogenic, and you get really intense vasoconstriction. So that is one of the downsides of any of these vasopressors, is that they can cause renal vasoconstriction. And so if you are needing to use high doses, that you can potentially cause acute kidney injury. So we do need to be mindful of the fact we use the lowest dose of our vasopressor possible to achieve our target blood pressure. Let me see. What have we got now? Should we intervene with an inotrope even if blood pressure is still in the normal reference? Sean, that is an awesome question. And that's an interesting question as well. If you read the Surviving Sepsis guidelines, they don't suggest that we routinely use positive inotropes. But when I would use a positive inotrope, and I have found this to be very, very useful, is if, let's say you've got normal systolic arterial blood pressure, but you have a patient who has poor urine output and is developing azotemia, and they're a patient with sepsis, then I would be using dobutamine in that patient in order to improve cardiac output. And I have seen, based on probably the 6 or 7 cases that I have used it in that particular scenario, and there have been patients, 3 of them were patients with snake bite or tick paralysis that had aspiration pneumonia and sepsis as a result of aspiration pneumonia, that had azotemia but normal blood pressure and poor urine output. I gave those patients dobutamine to improve cardiac output. Urine output improved, the azotemia all but disappeared. So I think that it has a use in those situations. So that's generally when I would consider using it. If you've got evidence of poor tissue perfusion, but your blood pressure is normal, then apart from, checking your blood pressure, making sure all of that stuff is working properly, that's when in a patient with sepsis, I might consider use of dobutamine in its own right. Hopefully that answers your question. Let's talk about albumin transfusions now. Albumin transfusions, why are we talking about it? Well, low albumin concentration is associated with increased mortality risk in both people and animals. But unfortunately, albumin transfusion is not associated with improved survival. So there are a bunch of diseases that are going to cause patients to develop potentially low albumin concentrations, and I'm not going to go through all of those. Why don't we just give patients with low albumin some albumin? It might make us feel better. Well, albumin transfusions can cause hypocoagulation. They're actually pro-inflammatory. They might have a mild, so those are the bad things, but they might have a mild kidney protective effect, and they may help influence repair of endothelial glycocalyx. Endothelial glycocalyx, if you're not aware, is just a complex layer of glycosaminoglycans and proteoglycans and a whole bunch of other stuff that line the inside of every blood vessel that we have in our body. And it's a protective layer. It helps to protect the vascular endothelial cells against damage. It reduces capillary permeability. It is involved in reducing the rate of coagulation in circulation as well. So when the endothelial glycocalyx gets damaged like it does in severe systemic illness, then repair of glycocalyx becomes potentially a significant thing. We don't know enough about that to know whether albumin transfusions might influence, but we know that albumin is a component of endothelial glycocalyx, so there's potential that it might have some positive effect. So what does the literature say about albumin? Well, it's conflicting. There's some good news about albumin transfusions and some bad news. Human serum albumin, glad we had a question about that, can effectively raise albumin concentrations, but in dogs, it is associated with a 20% risk of severe, potentially fatal hypersensitivity reactions, and in a single case report, the animal survived only because they used therapeutic plasma exchange. It is currently not recommended for use in dogs. I would not give human serum albumin to a dog, definitely not to a cat, even if it was the only option that I had available. There is simply not enough evidence that it's safe enough and it potentially could kill the patient. What about canine serum albumin? For those of you who have canine serum albumin, it's available in concentrations between 5 and 16%, or even 25% actually, based on the bottle that I've got on the screen. It can effectively raise albumin concentrations. It leads to an improvement in clinical signs, but the studies in dogs suggest there's no change in mortality. However, we've got very small sample sizes, and that prevented actually any conclusion being made in the papers that have been produced, despite higher albumin being associated with reduced mortality in broader populations. So we simply don't have enough data in dogs and dogs to be able to comment on that. Cryopore plasma, or cryosupernatant, has been used in dogs to raise serum albumin concentrations, and it led to improved clinical parameters, including blood pressure and urine output in some patients. So we had a question: what if you didn't have a positive inotrope in your practice or a vasopressor, but you have got some cryosupernatant? Then maybe you could use this to help improve perfusion in your patient. You might get an improvement in blood pressure and urine output in some of your patients. It is quite expensive, and that's a big downside to it. Reviews in patients with sepsis that had albumin transfusions said that either there was lower mortality or no difference in mortality. There's a bit of a mixture. That universally higher albumin concentrations were associated with better mean arterial blood pressure and less time on vasopressors and lower net fluid gains. All of these things sound like they might be helpful for patients with sepsis, but there is really no clear benefit in terms of reducing mortality, but a bit of evidence in improving hemodynamics in our patients. So what should we do? Should it be up to us to decide? And probably yes. I'm not saying that all albumin is good or all albumin is bad. When would I use it? Well, if I want to avoid fluid overload, which I think I'm talking about next, and I need to help maintain my patient's systolic arterial blood pressure, and maybe I've got my patients on vasopressors, maybe I'm maxed out on the doses there, but my patient is still a little hypotensive and it's hypoalbuminemic, maybe I should be using or considering the use of albumin in those particular patients to essentially reduce the amount of crystalloid that I need to use in my patients to help maintain normal circulation. What about plasma, fresh frozen plasma? Well, there's no evidence of any improved outcome in sepsis. There's an increased mortality rate in several studies using fresh frozen plasma, and there's an increased complication rate as well following plasma transfusions due to immune suppression and increased risk of worsening clinical outcome. So when should we use fresh frozen plasma in patients with sepsis? If they're bleeding and they've got a coagulopathy, and if they're bleeding or they've got a coagulopathy and I want to take them to surgery. So those are the two times when I'm going to use fresh frozen plasma, use it early. Use it early in systemic illness if you need to, if your patient's got coagulopathy, or as soon as your patient's got a coagulopathy and they're bleeding into a body cavity, be it the chest, the abdomen. You've got evidence that they're bleeding into their urinary tract or out their nose, wherever you've got, or if you need to do surgery. Now, I'll clarify surgery. If I need to place a nasogastric tube and I've got a patient with a coagulopathy, they'll probably get fresh frozen plasma because those patients will likely bleed. What about whole blood transfusions? Whole blood transfusions, thanks, Shell, for asking the question. Whole blood transfusions, I'm going to use in a similar way to what I've just recommended on the slide here, with the addition that my patient needs red blood cells. And if my patient needs red blood cells, typically they'll need red blood cells if their hematocrit, their PCV, is between or less than 20 to 24%. Any lower than that, and my patient will probably start to mount a physiological response, stress response to the fact that they have inadequate oxygen carrying capacity in the blood. In septic patients, anemia usually develops quite quickly over a few short days. So usually there's not much time for these patients to compensate for an acute drop in red cell count. So my transfusion trigger, if you like, is usually a PCV that's in the vicinity of 20 to 24%. And I'm going to transfuse them with whole blood or packed red blood cells to increase their PCV up to around 27 to 30% only. So I'm not necessarily aiming to normalize my patient's PCV. I'm just going to try and get it up to around 27 to 30%. Albumin transfusions for a septic diabetic dog. Any comments? Would there be an alternative to if this isn't an option? That's a difficult one. If the albumin concentration is low, probably cryopoor plasma because there's less stuff in there. So the cryosupernatant that we talked about just before, because there's less other protein molecules in there that might lead to adverse reactions. I certainly wouldn't be using, you could maybe use canine-specific albumin if it was a dog. I wouldn't be using human serum albumin on that patient. But these patients are immune suppressed as well if they're septic diabetic patients, so they may be in need of some immune stimulation. Let's talk about fluid overload for a second. We've spoken a tiny bit about it already. It's basically a positive fluid balance in a patient that's receiving or has received intravenous fluid therapy. If your patient has too much fluid, it's associated with increasing morbidity, organ dysfunction, and I'm talking acute kidney injury here, gastrointestinal dysfunction, liver dysfunction, cardiac dysfunction, pulmonary edema, and so on, and more mentation, and it's associated with higher mortality risk. What causes it? Well, either we're giving too much fluid or our patient has decreased cardiac function, maybe due to that platelet activating factor and nitric oxide we talked about before. Maybe there's underlying heart disease like cardiomyopathy, for example, or severe congestive heart failure. Or maybe my patient has increased capillary permeability, which we know happens in severe systemic illness due to the release of inflammatory mediators that increase capillary permeability. Or maybe my patient has decreased kidney function and they're not able to excrete the fluid that I'm giving them. The symptoms of fluid overload in the lungs would be pulmonary edema, characterized symptomatically by usually an increase in respiratory rate, or you might get an increase in pleural fluid accumulation. You might be able to detect fluid with a lung ultrasound as well. In the heart, symptoms of fluid overload might include cardiac arrhythmias and maybe an increased requirement for positive inotropes and vasopressors to help maintain normal systolic arterial blood pressure. Or if you're evaluating cardiac function with an ultrasound, you might see impaired systolic or diastolic function as well. As far as the kidneys are concerned, the kidney interstitial pressure will rise inside the kidney parenchyma, and that will because the kidney will swell against the renal capsule here, and that'll compress some of the capillaries in the renal cortex and will reduce kidney blood flow and glomerular filtration rate and can cause acute kidney injury. So I know as veterinarians, we're oftentimes taught that, if you've got suspected kidney damage, that more fluid is good and less fluid is bad, because we need to give our kidneys more fluid to flush them out to help improve perfusion. But you can give too much, because imagine in septic patients, you've got leaky capillaries all throughout your body, including in the kidneys. And if I give my patient lots of fluid, I'll just get increased kidney interstitial pressure. That's going to lead to kidney swelling and compression of blood vessels right throughout the kidney parenchyma, leading to reduced kidney blood flow and glomerular filtration rate and acute kidney injury. So you can cause acute kidney injury by giving too much fluid. In terms of the brain, when that gets too much fluid, we get cognitive impairment, increase in intracranial pressure. You might find your patient's pupils become small and poorly responsive, or dilated and poorly responsive. Patients, if they've been anesthetized for whatever reason, maybe you're doing surgery for source control, maybe these patients might take a long time to wake up from their anesthetic, or they may be delirious. They may have evidence on CT or MR of cortical necrosis. In terms of the gastrointestinal tract, we get ileus, we get impaired liver function, increased intra-abdominal pressure, which causes a decrease in blood flow to all of the organs in the abdomen, and increased intestinal wound infection rate. So if you've done surgery to repair remove an intestinal foreign body, or to repair an intestinal perforation, your poor little surgery site will do worse if your patients are volume overloaded. Skin and muscle, we just get edema, weakness, and delayed skin healing as well. So the evidence that we have is pretty significant that we get all of these things happening in patients with volume overload, as well as increased mortality rates in our patients. So how do we prevent it? Well, essentially, we limit our shock rates of fluids to patients that are responding. What does that mean? So my shock rates of fluid for a dog are like 10 mils per kilo in 10 minutes of a fluid like lactated Ringer's solution or Ringer's acetate solution, or 7 mils per kilo in 10 minutes if it's a cat, okay? If my dog or my cat does not show an improvement in heart rate and blood pressure in that 10-minute bolus, the most I will do is give them maybe 1 or 2 more boluses of IV fluid. So I might give them 2 boluses of 10 mils per kilo in 10 minutes. So 20 minutes worth of fluids at 10 mils per kilo in 10 minutes for dogs. Or I might give my patients, 20 minutes worth of 7 mils per kilo in 10 minutes for a cat. So the cat will get 14 mils per kilo in 20 minutes. The dog will get 20 mils per kilo in 20 minutes. If my patient's heart rate, their pulse quality, their blood pressure does not improve, then I'm going to reduce fluid rates to maintenance, because that patient is not fluid responsive. And then I might start to give my patient, if I need to maintain normal systolic arterial blood pressure, that's when I'm starting to use noradrenaline to help maintain normal blood pressure. The other thing we can do is just to avoid giving our patients higher than maintenance rates of fluid to replace fluid losses from my patient. So what do I mean by that? Let's say we've got a parvovirus enteritis patient. It's got diarrhea every 20 minutes or so. Rather than have my patient on twice maintenance fluids to keep up with the rate of fluid loss in its diarrhea, I'm going to have my parvo patient on maintenance rates of fluid. And then every hour or 2 hours, I'm going to weigh my patient, and whatever fluid that patient has lost, or whatever body weight change I see, I'm going to give my patient over the following hour. So essentially, I'm playing catch up with my fluids. My patient will be a little bit dehydrated, but not too much, hopefully. And I can catch up in the next hour or so with a bolus of IV fluids over 30 to 60 minutes or so, rather than to give my patient excessive rates of IV fluids that might cause some of the problems that I've got. So avoid continuous infusions of supranormal replacement fluid rates. Note that I've still got to rehydrate my patient. So if I've got a dehydrated patient that's in shock, I'll treat shock. I'll have them on maintenance rates plus rehydration rates for 12, 24 hours, however long it takes me to rehydrate the patient. And then I'll decrease the fluid rates then to maintenance rates, and then just monitor for ongoing losses. If your patient develops pulmonary edema, stop your IV fluids and give them furosemide as a CRI, or maybe 1 to 2 milligram per kilo every sort of 2 to 4 hours or so to help clear that edema. I just want to finish off now by talking about the Surviving Sepsis campaign. We talked about this. Oh, what about colloids and hypotension patients? Atija, I hope I've pronounced your name correctly. That is a lovely question, and I'm really pleased that you asked it. Synthetic colloids, and I'm guessing that's what you're mentioning, synthetic colloids have no place in the treatment of patients with sepsis or severe inflammation. Based on 2 landmark studies that have since been backed up by others that demonstrated an increased risk of acute kidney injury and a slight increased risk of mortality with synthetic colloid administration versus a balanced isotonic crystalloid solution like lactated ringer solution or acetate ringer solution. So we don't use synthetic colloids like hydroxyethyl starch anymore in severe septic patients or patients with severe systemic illness. We don't even use them in patients with GDV anymore. And you can use them in acute patients, acute post-trauma shock patients if you need to, or patients that have got healthy glycocalyx, so patients without systemic illness, so your patients that have got perhaps hypotension during anesthesia. If you feel that they are fluid responsive, if they've lost fluid, then you can give them synthetic colloids then. But beyond that, in systemically ill patient, we don't use them at all anymore. Great question. Zhao, so the ancient recommendations to hyperperfuse by up to 4% in kidney patients should be discontinued. Yes. We discontinue that. We're aiming for normal hydration in our patients and normal systolic arterial blood pressures, but no hyperperfusion or hyperhydration for those patients. Is there any consideration when giving shock doses to anemic patients? Should it be calculated differently? So that's another great question. And the short answer to your question is yes. We do need to think about those patients more carefully. So if I have a patient who is already anemic and they're in shock, I'm going to need to give them shock rates of fluid and a blood transfusion. If my patient's PCV is 20 to 24%, a blood transfusion is part of my fluid resuscitation plan for that patient within the first hour of presentation. If my patient has a PCV of 27 or 28%, before I give it shock rates of fluids, I know that the hemodilution that I'm going to cause by giving my patient a bolus of a crystalloid fluid like lactated ringer solution, I might cause some hemodilution. So I'm typically giving those short boluses every 10 minutes or so. And if I find that my patient's tachycardia gets worse or that my patient's not responding to fluid therapy, yes, I would repeat another PCV total protein. And if my patient's PCV had dropped down towards 20 to 24% as a result of the hemodilution, I might need to consider giving them a transfusion then. So you need to keep, that is one of the things that could cause your patient to not respond to shock rates of fluids. Do I have a particular anti-inflammatory drug that I would use? I don't use anti-inflammatory drugs in patients with sepsis. They don't really have a place. They don't do what we thought they did. It would be lovely if they did, like corticosteroids and non-steroidals, but there are risks to giving those drugs, and they haven't been associated with improvement in outcome, and they have been associated with increased complication rate, both GI as well as kidney. So I don't use any anti-inflammatory drugs in these patients. If you were to draw on the slide here on the screen, the inflammatory cascade, the part of the screen that would be covered by an anti-inflammatory dose of non-steroidals or steroid anti-inflammatory drugs is about that big, just down in the corner. All of the rest of the screen will be filled up with the actions of interleukins, tumor necrosis factors, chemokines, other cytokines that we have, platelet activating factor, all of those other things that are involved in inflammation take up the rest of the screen. The lipoxygenase pathway and the cyclooxygenase pathway, tiny little bit in the corner. So it's not really surprising, I guess, that drugs like corticosteroids and non-steroidals haven't really resulted in an improvement in survival in our patients. But thank you for asking that question. I really love these questions because they're practical things, aren't they? We want to feel like we're doing something. So let's just have a look now, just before we finish off, and I apologize, I've gone over time, but surviving sepsis guidelines were established back in 2004, and they use the current evidence base to make recommendations for the treatment of patients in sepsis. They're updated about every 4 to 5 years. They're decided on by a committee of experts. They have developed these care bundles to help standardize care. Unfortunately, we don't have strong recommendations for some of the recommendations that are made in the surviving sepsis guidelines. So when you're reading them, do take note of the quality of the evidence that has been used to make a recommendation. Some are just based on expert opinion. And if you were to put a room full of experts in if you were to take a bunch of experts and put them in a room and ask them about their opinion on a particular topic, you're likely to get several different opinions. So some of the evidence is not that strong for some of the recommendations. However, having said that and recognized the faults in the system, the greater the number of the bundles that that are included in the surviving sepsis guidelines are applied to the patient, the lower the mortality rate. This is great. This has been proven in scientific literature. Bundle compliance. So if you actually adhere to the 6-hour bundle and the 2-hour bundle and so on, mortality rate in people is reduced by up to 40%. 40% reduction in mortality rate. I want to be in a hospital where they are really compliant with bundles if I have sepsis. I'm sure that you would be the same. You also have less time in hospital, so you don't get to eat all the bad hospital food as well. So I think that there's strong evidence to suggest that an approach to these patients that is standardized, and basically by standardizing it, what I mean is that we're basically making sure that you and I don't forget about certain things when we're treating these patients. I put a couple of examples here taken directly from the Surviving Sepsis campaign. It's free if you download Surviving, or you Google Surviving Sepsis campaign, latest guidelines. I think the latest ones were 2021 or 2020 or thereabouts. So these are their recommendations. This is human data, but I think it informs us a little bit about how sometimes we might consider managing these patients. And there's another one here with antibiotic timing. Sepsis is definite or probable. Consider antimicrobials ideally within an hour. Sepsis is possible. Administer antimicrobials, ideally begin within 1 hour, and reassess your patient and I think we had that question earlier on, how do we decide sepsis versus systemic inflammation? This kind of lets us know that if we're worried or we think sepsis is possible, we're still going to try to administer antibiotics, because mortality rate just increases so much more for every hour we delay them. There's also one of the examples of the bundles here. This is the 1st-hour bundle where you measure lactate, can obtain blood cultures. If you have got a patient with sepsis, administer your antibiotics, begin fluid administration, apply vasopressors if they're hypotensive during or after the initial fluid resuscitation within 1 hour. So the lactate thing is an interesting one, because lactate concentrations may not decrease by much at all for up to 12 hours. In fact, survival rate is still reasonably good if you have sepsis, if your blood lactate concentration only decreases by 40% within the first 6 hours. So I think that some of these things, the little asterisk that's there, is not necessarily potentially all that useful for us. I think that we'd need to consult a specific reference on how quickly blood lactate concentrations decrease in sepsis, because it is a lot slower than they tend to suggest in the surviving sepsis guidelines. So conclusions, wrapping it all up: improvements in mortality rate from sepsis are possible with early recognition, early antibiotics, early source control, early application of bundles, and early vasopressor and inotropic use. We need to be careful with fluids and transfusions. I didn't mention glycemic control except very broadly, but if you have a hypoglycemic patient, give them glucose. If they're hyperglycemic and sustained hyperglycemia, then put them on an insulin CRI. Manage those patients as if they're diabetic, because peripheral insulin resistance is a thing in septic patients, and use a daily patient checklist so that you're not forgetting about anything. I'm going to answer a few questions there. How much fluid should we give after our 10 mils per kilo bolus and it's worked, but decreases after 5 to 10 minutes after we've given our bolus of fluid? So if you have a fluid responsive patient, that is, their heart rate decreases a little bit, you get a bit of an improvement in blood pressure, but then a short while later, their blood pressure falls, their heart rate goes up again, and you give them another bolus of fluids, you would give fluids until your patient was no longer responding, up to about 30 minutes or so. There can be a number of reasons why your patient might only temporarily respond. They might be bleeding somewhere. They may be accumulating fluid into a body cavity, for example. They may have really poor vascular tone or increased vascular permeability. So I don't normally like to go beyond about 30 minutes if that's the situation. I'm really searching for other reasons why my patient is only temporarily responding to fluid therapy. How about antibiotics? What's the safest drug to be used in sepsis? I would be using beta-lactam, so either amoxicillin clavulanic acid combination or first generation cephalosporin. They're really useful drugs to use as a front line. As I mentioned, if I've got a really sick patient, got a low white blood cell count, I might add in metronidazole and or a fluoroquinolone like enrofloxacin, but that's what I would be thinking about as my initial choice. How about hypertonic saline? Jeff, thank you so much for asking that question. Hypertonic saline, and I did want to mention saline because any type of saline, be it 0.9% sodium chloride, 3% sodium chloride, 7.5% sodium chloride, are associated with increased mortality rate in patients with sepsis, and they are associated with increased pro-inflammatory mediator release, and they are associated with increased rates of infection. So I would not use them at all. That's a really good question. So the best fluid you can, so that's both 0.9% sodium chloride as well as all of the more concentrated solutions like hypertonic saline. So saline is kind of off limits for sepsis. And I think as veterinarians, most of us use balanced crystalloid solutions like lactated Ringer's solution or Ringer's acetate solution, and they're great to use. There's two examples there. Because they're balanced, they're not as acidifying, they're lower in chloride concentration, and those things seem to make a difference. Oh, the other thing that was documented with saline use in septic patients is higher rates of acute kidney injury as well. Krista, would I rely on systolic blood pressure or mean arterial during resuscitation? It really depends on what you have available and what you can get to work on your patient. Some septic patients with lots of peripheral edema, sometimes the mean arterial pressure that you might get on a oscillometric blood pressure monitor can be a little bit variable. If you find your machine, your automated oscillometric machine is having trouble getting a blood pressure reading, then I would go for a Doppler and just use systolic. Let me see. I have a couple of things to mention. You guys have been amazing sticking around. I said there was a special gift, and here it is, 15% off the course that we are running next week. Okay, so that is quite a significant amount off. So you can scan the QR code or go to the little bit.ly link there as well if you did want to join us in the course. We're going to delve into this stuff in a lot of detail, give you standard operating procedures or protocols for managing some of the various illnesses. We're going to talk a lot more detail about fluid therapy and transfusions and those kinds of things as well. So that is what I'll just leave that slide up for a second. But I do want to thank you all tremendously for taking time out of your day. I think at peak we had well over 200 people in the webinar. So thank you so much for coming along tonight for this lecture. I apologize we went a little bit over time. I hope that some of you will be able to join us for the course next week. Take care, everybody. I wish you a very, very happy remainder of your evening or remainder of your day. It's been an absolute pleasure to spend time with you, and we hope to see you all again very, very soon. Thanks, everyone, and good night.